My name is Tia Higano. I'm a medical oncologist from the University of Washington, and we're here tonight to hopefully help you have a better understanding of metastatic prostate cancer. And that might sound simplistic, but by the end of the evening, you'll probably agree with me, it's not so easy necessarily. I just want to briefly introduce the panel members. Andy Armstrong is on my immediate left, and he's from Duke. Alan Bryce is from Mayo Clinic, Scottsdale. And Tanya, on my far left, Tanya Dorff, is from University of Southern California. So we picked people from all areas of the country so that you would get different perspectives. And two of us, by the way, do sit on the NCCN prostate panel, Dr. Armstrong and myself. We also have some consulting faculty that will have answered some questions remotely, Dr. Maha Hussain and Dr. Dan Petrolak. And you'll see the answers to their questions as we go through the evening. The agenda will be self-explanatory as we go through. So again, our topic tonight is metastatic prostate cancer, and I first would like to discuss the so-called disease states, because in prostate cancer, we do something a little different from some other cancers where we talk about stage 1, 2, 3, and 4. I mean, clearly metastatic disease is stage 4, but there's all kinds of permutations. And then I wanted to quickly address some of the changing understanding we have of patients with metastatic disease. And a lot of this is based not only on phase 3 trials, but some of the data that was presented today in the poster sessions. I'll quickly review the treatment options by disease state and by the NCCN guidelines. And finally, we'll review the learning objectives and proceed with our cases. So this slide's going to talk about all states of prostate cancer. And, you know, we have two buckets that we think of patients and falling into. One is hormone-sensitive disease, or also an evolving name for this is castration-sensitive, but since this isn't in wide terminology yet, it's in parentheses. And so these are patients who are going to respond to lowering testosterone levels or some other form of hormone therapy. And then we have patients with castration-resistant disease who are no longer responding to frontline hormone treatments. And in the hormone-sensitive bucket, we have the patients with newly diagnosed disease, of course, those who relapsed after some form of initial therapy, radiation or surgery, who are non-metastatic hormone sensitive. And finally, we have those with metastatic hormone sensitive disease. These are the patients who were studied in CHARTED and STAMPEDE and JETUG 15. Then in the castration resistant categories, we have those with non-metastatic castration resistant disease and those with metastatic. And underneath metastatic, we have the categories that I've put down here, mainly because these sort of help you understand where the phase 3 clinical trials have been done. First in the asymptomatic pre-chemotherapy patients, those who are symptomatic or chemotherapy naive, and those in the post-docetaxel setting. So we're going to be talking about only those with metastatic disease. In the castration, in the hormone-sensitive situation, there's two ways we can get to metastatic disease. And this is going to be really important for us to understand moving forward. One is the guy that had, surgery or radiation for initial disease, then relapse with PSA relapse or so-called biochemical relapse, and then became metastatic, but still hormone sensitive because they hadn't, for whatever reason, been treated with hormonal therapy. The other way is what we used to see in the pre-PSA era. Is anyone here in the pre-PSA era besides myself? Right. And these are the guys who just walk in the door with metastatic disease and never had prostate cancer before. So there's two ways, okay? The guys that sort of progress from primary, so M0 disease, and those who present initially with M1 disease. So what we heard about in this meeting was that, this is a really hard number to get a handle on these days. Like how many of these patients with de novo M1 disease are there? And this poster that was given today by Dr. Bernard et al. Looked at a large number of patients in the SEER database who were diagnosed with prostate cancer, and looked at patients who were diagnosed with prostate cancer based on age and race. And what they found was that the frequency of de novo M1 disease is higher, and cancer-specific survival is lower in older men over 75 years old. And the patients who are of African American descent don't do as well. There's more of them. Now, a sort of related poster looked at, again, the impact of prior therapy on outcome in men with metastatic hormone-sensitive disease. So definitive treatment, or those who had some kind of primary treatment before, compared to those who walked in the door with metastatic disease, this is what they found, and these differences. First of all, the de novo guys, you can see, have more visceral disease, have lower ECOGs and Gleason's and so on. But most importantly, the take-home message is that the time to develop castration-resistant disease is much shorter in men who walk in the door with metastatic disease, and the overall survival is also significantly lower than those who had more indolent disease. Now, it's interesting that these posters are actually supporting a comment that Ian Tannock made last year when he was discussing the STAMPEDE data. And in his discussion of that, he said, we really need to take into account these two different populations because there's no data, but my clinical impression, and many people's clinical impressions, has been that the guys who walk in the door have more aggressive disease. And these papers just prove that he and many of us who sort of had this intuition, actually, this is correct. So, when we give patients with non-metastatic hormone-sensitive biochemical relapse, ADT, we know they can progress to either non-metastatic or metastatic castration-resistant disease. And the same thing in patients with metastatic hormone-naive disease. Now, tonight we are only going to talk about this group of patients, although Dr. Armstrong is fully prepared to talk about the non-metastatic CRPC patients if there's interest. But in the interest of time, we've asked him to hide those slides unless there's specific questions, but we are prepared to deal with that if you wish. Now, in terms of castration-resistant disease, this third poster that was presented today that I want to mention to you gets back to this whole thing. Well, okay, if you take a bunch of guys with metastatic castration-resistant disease, what you will see is that the median time from diagnosis to castration resistance is significantly longer in those patients who presented with primary disease and were followed over time. Whereas those who walked in the door, the time to castration resistance is significantly shorter. So again, a higher percentage who presented with de novo M1 disease at diagnosis had aggressive metastatic castration-resistant disease. And so the M status at initial diagnosis may be prognostic. And it's interesting because we have not used this in the design of our clinical trials heretofore. Again, getting at numbers, like how many patients, have M1 disease. I mean, Howard Scher presented this paper recently, and the reason I put this in is, this de novo guys walking in the door with M1 disease, it's there, and we're going to be talking about very relevant clinical data, but in fact, it's not the majority of men with metastatic prostate cancer in this day and age. Most of the men have metastatic castration-resistant disease, so just keep that in mind. It's not always a continuum from metastatic hormone-sensitive to metastatic castration resistance. That's the exception rather than the rule. So the NCCN guidelines, I'm just going to quickly, I'm not going to go through all these options because that will be for our speakers to talk about in their cases. But I do want to mention the M1 patients. These are all the options, and we're going to talk about these. And then, but because of the charted data that you all are pretty familiar with by now, we're going to have to answer the question about should all M1 patients get docetaxel. And I'm not going to belabor this slide because, in fact, Alan Bryce will be talking about this in more detail. But if you want to read a quick 2-page summary that I wrote about this, this is here if you want to look at it, but I'm not going to talk about that. So in the castration-resistant setting, first of all, this is probably familiar to all of you, but I just want to redefine it so we're all on the same page. The things that you need to be considered castration-resistant is that you need to have a serum testosterone level in the so-called castrate range, which is less than 50 nanograms per deciliter. Although some people like to make it lower, but for all intents and purposes right now, 50 is the number. And then you can either have castration resistance by virtue of an increasing PSAs or by progressive disease on imaging, but usually it's at least increasing PSA on ADT and maybe progressive disease on imaging. And just to remind those of you who might not have kept up with this, we used to call this hormone refractory or androgen independent, and it turns out that neither one of those, as we understand the biology of the disease better, is entirely accurate. So when we look at the options for metastatic castration-resistant disease, these are the recommendations, and again, this is going to be dealt with by Andy Armstrong in his talk, with one exception, and that is that he won't have time to talk about the bone anti-resorptive therapy, so I am going to briefly discuss that now. So prostate cancer spreads to the bone predominantly. Patients can experience skeletal-related events, and this has been around for many years, this clinical trial endpoint, but this includes radiation to bone, pathologic fracture, spinal cord compression, surgery to bone, and in other malignancies, it includes hypercalcemia. That is not a bullet on this slide because hypercalcemia, although prostate cancer is bone dominant, is extremely unusual in prostate cancer. And just to review, this has been around now, zoledronic acid's been shown to be superior to placebo in terms of preventing or delaying SREs and improving pain scores, or actually decreasing the increase in pain. So the zoledronic acid was approved in 2002, and then it was compared head-to-head with denosumab, and these agents are both very good. Neither one of them impacts overall survival or time to progression, but the main reason that denosumab was approved is because there was a significant improvement in median time to first on-study skeletal-related event. Now, the thing to remember is there are differences between these agents. You probably know all this, but I think I really want to point out a couple things besides the routes are different, the mechanisms of action are different, schedules are about the same. Zoledronic acid, we need to watch renal function, whereas that's not a problem with denosumab. Acute phase reactions, that's where there's a difference. Both do have been associated with ONJ, so it's very important to address dental hygiene prospectively in our patients. Hypocalcemia is more prominent in denosumab. And again, neither one of them causes any difference in survival when combined with whatever therapy. Now, interestingly, there is a slight difference in the FDA approval for each drug. Zoledronic acid is approved for metastatic castration-resistant prostate cancer, whereas denosumab is approved for any bone metastases. These are the NCCN guidelines with respect to this therapy. Both drugs are effective. Neither agent improves survival or PFS. ONJ, I talked about that. But the thing to keep in mind is, at least by NCCN right now, it's not recommended in metastatic hormone-sensitive disease with bone metastases. And really it's because of lack of evidence. Anything you see in the NCCN guidelines is all evidence-based. It's actually a slide that I've been using for a number of years, only to rationalize in my own mind how I think about a patient when I have him in front of me, and what treatments are available. So if you have a guy with metastatic castration-resistant disease and he's asymptomatic or minimally symptomatic, I know from this list, these are the agents I could offer this patient that have level 1 evidence for improving survival. In a patient who's symptomatic and not had chemo yet, again, we can give docetaxel, we can give radium-223. These are the areas where these agents have been studied. And then in terms of palliation, these drugs have been shown to be beneficial. But if a patient's sitting in front of me and has already had chemotherapy, docetaxel in particular, all of these agents have been studied in the post-docetaxel setting and have shown to extend survival. So I just use this as a quick and dirty. I mean, I actually prefer to use this, but you can use whatever you like to help you think about what's best for your patients. These are all the agents that have been studied and were in green on the prior slide. And the only thing I want to point out here is that if you really look at the median overall survival benefit for all of these agents, they're all in the same ballpark. 3 to 4 months improvement compared to whatever they were compared to. So, we haven't hit a home run, but it's pretty good now. We have all these different agents that do something as far as survival, which compared to when I started out, there's absolutely nothing. Now, I wanted to just mention this recent paper that was published by Susan Hallaby about where is the disease in patients with castration-resistant disease and how does that impact how they do. And, patients, it turns out that patients with lung metastases, even though we usually lump these in with liver as being quote-unquote visceral, actually do about the same as men with bone-only disease. Whereas men with liver metastases clearly have the poorest survival, and the guys who have lymph node-only metastatic CRPC do the best. And, we've known that, but it's nice to see it in writing. But the reason I wanted to show you this has kind of been an impetus for changing the NCCN algorithm to some extent, because at one point in time, we made a decision based on symptoms, and now it's gone to the presence or absence of visceral disease. So this is what the algorithm looks like for metastatic CRPC. Is there visceral disease, yes or no? The main thing is I want to point out in the patients who have visceral disease and have not had a lot of prior therapy, the category 1 recommendations are for docetaxel and enzalutamide. Now, abiraterone is not at category 1 for visceral metastases because it, in fact, excluded patients in the phase 3 trial in this situation, pre-docetaxel. In patients with no visceral disease, this gets a little messy, but the visceral disease, yes or no, there's a whole list of things, and I'm not going to belabor the list, but when you get to visceral mets, the basic rule is these patients are not eligible to get either Sapulacel-T or radium-223. I mean, that's how I boiled down this slide. Anyway, so getting back here, this is the overall compilation of the NCCN guidelines put in my way of thinking of it. So you can take that or leave it. Whatever works for you is the best thing to look at. The discussion points for tonight, what we're trying to accomplish is to have you understand the evidence-based treatment options for men with metastatic prostate cancer, whether it's hormone sensitive, which I said is a minority of patients, or castration resistant. and then appreciate the importance of symptoms, pattern of spread, overall health, risk benefit, and patient preferences, and how they might influence the choice of therapy for that patient. And then to become familiar with some of the challenges, I would say, of sequencing therapy for patients with metastatic CRPC and the opportunities for clinical trials. So the overview of tonight will be that we're going to present cases of metastatic prostate cancer to address these learning objectives. And Alan Bryce, Andy Armstrong, and Tanya Dorff will be presenting a case or two each. And what we'll do is we want to give the audience the opportunity for interacting with us as we go through it. We want it to be, you know, like live, real time. So when we get to ARS questions, what we're hoping is you might engage in a discussion with others at your table, you know, and maybe come up with some questions. We'll take questions. People will be walking around with microphones, or you can wave at us and yell. And we'll also have input from the two people who aren't here, Maha Hussein and Dan Petrolak. So at the end, you know, after you give your answers, we'll get to see our answers and their answers. So with that, we'll go ahead and start with Dr. Bryce. Thank you.
Thanks, Tia. I'm going to start on the first topic. We're going to kind of walk through the disease states from early to late. And I'm going to talk about the topic of hormone-sensitive prostate cancer, metastatic hormone-sensitive disease, whether we call it hormone-sensitive or castration-sensitive or whatever terminology we prefer to use. You know, and obviously the reason for this topic is the change we've seen in the field in the past couple of years with the data that's come out from now 3 groups in the US and the UK and in France, looking at specifically the approach to the treatment of these patients and whether or not we should be moving chemotherapy earlier into the treatment paradigm. I want to start out with a case, and as we said, we do want to make this interactive. So the first case is we have a gentleman, 70-year-old man, a typical patient who had his prostatectomy 6 years earlier, had Gleason 4+3 disease at that time. Subsequently had a biochemical recurrence and underwent salvage radiation therapy 18 months later. And eventually his PSA recurred again after another 28 months and is slowly risen now to 3.2. It's an otherwise fit and healthy gentleman, some mild hypertension, no history of coronary artery disease. He had elected to defer androgen deprivation therapy, not wanting to have these symptoms. But imaging now demonstrates multifocal bony metastasis with no evidence of nodal or visceral metastases. The bone scan is shown here. Just have a look for a second. So obviously multifocal disease. And then if you would discuss and vote on what therapy you would recommend to this gentleman. All right, so that's nice. We've got a range of answers here. So some people chose just androgen deprivation therapy. 21% said combined androgen blockade. 28% recommended LHRH therapy with docetaxel. And 33% wanted docetaxel with zoledronic acid and LHRH therapy. 5% said other, and no one is unsure.
That's great.
Can we ask what would the other be? And I wonder if it's no one wants to step up. That's all right. So we'll ask our discussants here. All right. So this is the only question of the ones we'll see tonight where the discussants all agreed, as it were. For the rest of the night, it'll be much more interesting than this, and I think we'll get much more engaged in terms of debating various options. But you know, I'm going to move past this example rather quickly, simply because this is at least the most straightforward case, talking about high-volume hormone-sensitive metastatic disease. And this high volume versus low volume is a definition that was created in the charted study, looking at 4 or more bone lesions versus 4 or more being high, or the presence of visceral disease. distinguishing this from high risk versus low risk, this is not necessarily risk, although it's often discussed that way and perhaps is thought of as a surrogate. All right, so moving into the topic then, the background here is that from 2013 to 2016, we've seen multiple randomized clinical trials come out, Charted in the US, Stampede in the UK, and then the first of them, GETUG 15 out of France, with varying results with regards to the impact of upfront chemotherapy added to ADT and its impact on overall survival, and then questions about patient selection, appropriate patient selection and subset analysis. GETUG 15 was the first to report out. This accrued from 2004 to 2008, the smallest study of the three, 385 patients, and it randomized patients to upfront androgen deprivation therapy versus androgen deprivation therapy, plus up to 9 cycles of docetaxel. It was noted early on that there was a surprisingly high rate of neutropenia and febrile neutropenia, so eventually growth factor was added to this study. And I'd have you note that there was no assumed or mandated corticosteroid here. So whereas we're mostly used to giving docetaxel with prednisone in this population, in GETUG and also in Charted, there was no prednisone included, although in Stampede there was. So at least now we can say we have clear data demonstrating, I would say unsurprisingly, that there is legitimacy for doing docetaxel without including a corticosteroid. So in GETUG 15, there was no apparent advantage to the addition of docetaxel to ADT, and the hazard ratio, as you can see, was as insignificant as possible. It was 1.01 with the confidence intervals, as one would expect, just evenly on either side of 1. The overall survival was 54.2 months in the ADT arm versus 58.9 months in the ADT plus chemotherapy arm. The 54-month overall survival with ADT alone does stand out from the other 2 data sets, and we're not quite sure why, but you can see in the French study, the patients treated with ADT alone clearly lived longer than in any of the other data sets. And then Charted came out 2 years ago. We saw this data here at ASCO, and this is really what started to change practice significantly, both first in the US and also in Europe. So in Charted, we had 790 patients with a pre-specified analysis that we'll talk about later of high versus low volume disease. And in Charted, there was a distinct overall survival advantage with upfront chemotherapy added to hormone therapy, and the hazard ratio on that was 0.61, with survival with ADT alone of 44 months and with ADT plus chemotherapy of 57.5 months. And then subsequently, the data came out from Stampede, and Stampede was a bit more complex study, and I'll get into this a bit more later in some slides, but there are multiple arms in Stampede. The comparator is traditional androgen deprivation therapy alone. Then there was an arm of ADT plus docetaxel plus prednisolone, 10 milligrams daily, and in Charted and Stampede, it's 6 cycles of docetaxel, not 9. And then in Stampede, there was a third arm of ADT plus docetaxel plus zoledronic acid, and we'll look at that data as well. But here again, you can see that the survival with ADT alone is on the order of 45 months, and then with the addition of chemotherapy, we get closer to 5 years, 55 to 60 months. And here again, hazard ratios were positive, favoring chemotherapy added to hormone therapy. So how do we reconcile this? How do we reconcile 3 disparate data sets? And this has been an area of active conversation for the past couple of years as all the data has come out. So walking through them separately, simply chronologically here, GETUG 15 being the first. This was the publication from Dr. Gravis et al. And really this is a very simple overall survival curve to interpret. Of course, these lines absolutely sit right on top of one another. There's no signal here to suggest that chemotherapy would be beneficial. So of course, practice remained the same. And really, this is why Charted was so surprising when it was finally reported out. In subgroup analysis, again, we couldn't identify any significant subgroup that was benefiting from the addition of chemotherapy, whether it's prognostic groups here, not volume. So this is risk groups, not volume of disease, but high, intermediate, or low. Perhaps you start to see some signal in Gleason, but it's certainly not definitive. Performance status, you can see really that performance status was generally very good, and this is a point that we need to address a bit more later on. But here again, there is no subgroup that jumped out from GETUG 15 as benefiting from chemotherapy. Then 2 years ago, Chris Sweeney reported these data, and this really changed the field. As opposed to GETUG 15, there was a distinct advantage, and the overall survival curves are very clear here. But here again, the addition of docetaxel appeared to lengthen overall survival by over a year when given in the upfront setting. And keeping in mind, and again, we'll look at this detail a bit more later, but this is not a question of should chemotherapy be given at all. This really was a study of early chemotherapy versus late chemotherapy, because the patients who get upfront androgen deprivation go on to get chemotherapy later. So it's really a question of timing rather than selection. But very relevantly, Dr. Sweeney's study looked at high versus low volume disease, again defined as 4 or more bony lesions as defining high volume disease or the presence of visceral metastases, and less than 4 being the low volume disease. And very clearly here in the low volume disease, there is not a significant signal. Even though the hazard ratio here is 0.6, very similar to what we saw in the high volume disease, there's not a lot of separation. And these curves, because of the limited follow-up, because of the length and the small number of events, these curves would be expected to be unstable. So all we could say from CHARTED 2 years ago is that high volume hormone-sensitive metastatic prostate cancer benefits from the addition of docetaxel. And this is the composite overall progression-free survival with addition of docetaxel versus ADT alone. And here again, you're talking 4 months of chemotherapy up front, lengthening the progression-free survival from 20 months to 33 months. So it's a trade-off for the patients of delaying time to next therapy by over a year by doing 4 months of upfront chemotherapy. All right, and here again, just looking at the subgroups, as you'd expect in CHARTED, we started to see some definition by subgroup. And here's your low volume versus high volume, 277 low volume patients, 500 high volume patients. All right, so moving on in STAMPEDE then. So we had to wait a year. Now we had 2 opposing studies, GETUG 15 and CHARTED, and we had to wait a year to find out if the British would break the tie between the French and the US, and of course they sided with us, as they should. So the STAMPEDE is a more complex study, and most of you are probably familiar with this. It's really an enviable study. I wish we'd have thought of this, or I could be involved in the study. It's fantastic. So it's been a rolling accrual, now spread over the course of several years, starting in 2006, where the control arm is ADT alone, but various comparator arms are added on as data changes, as new drugs become available, and patients are randomized 2-to-1 to control versus one of the experimental arms. And there were a variety of arms: zoledronic acid, docetaxel, celecoxib at one point has since been discontinued, abiraterone now going as well, radiation therapy up front, and then an enza-abi combination. And we're just going to look at the ones in yellow. So in STAMPEDE, this then, the tiebreaker, as we said, does favor the addition of docetaxel to androgen deprivation therapy in the first-line setting. And here again, these numbers are very similar to what we saw with CHARTED. In the zoledronic acid plus docetaxel arm, the results are very similar. I don't get into it here, but in fact, the comparison of does zoledronic acid with or without docetaxel add anything to overall survival, and the answer was definitively not. Zoledronic acid certainly doesn't add anything at all as far as overall survival for these patients. And so really the point of this is to demonstrate that it's the docetaxel that's benefiting patients. And here again, the hazard ratio 0.82, and the medians are consistent with the docetaxel alone data set. All right, so patient 2. And this is where the conversation comes in, and there is disagreement. And this is, I think, the more important point for the talk. So patient number 2, again, I'm starting with a very similar patient. It's going to be another 70-year-old gentleman, initial radical prostatectomy with Gleason 7 disease, underwent salvage radiation, then biochemical recurrence. So all of that is the same as our first patient, but now imaging studies only demonstrate 3 metastatic lesions, 2 in the spine, 1 in the right iliac bone, and here's a choline PET demonstrating the lesion. So let's discuss and vote. All right, so a good distribution of answers. So this is very helpful. So 29% of the audience chose LHRH therapy. 14% said combined androgen blockade. They must all belong to SWOG. 36% of patients said LHRH plus docetaxel. For 17% wanted to add zoledronic acid. 5% fair enough are saying other, and 6% are nobody saying unsure. Very good. All right, so our panel offers a variety of answers, and certainly I think this is where it gets a bit more interesting. Much like the audience, certainly androgen deprivation therapy is appropriate. The question is, should we add bicalutamide? Should we add chemotherapy? Certainly the panelists wouldn't add zoledronic acid because of the data not supporting it in the hormone-sensitive setting. But here I'll ask our colleagues. I'll start with Dr. Dorff. Do you want to contribute? Why combined androgen blockade?
So I believe in the SWOG data showing that combined blockade is slightly superior to monotherapy. And if you look at some of the retrospective data, some of it may be about the sloppiness of our LHRH therapy and testosterone breakthroughs and having that second layer of blockade. So I think physiologically makes sense, and there are data to support it.
See, I told you it was a SWOG phenomenon.
It is a SWOG phenomenon. We recognize that. And fair enough. Certainly, I mean, there's no question compliance is always an issue. In this day and age, you wonder about some of our patients supplementing their testosterone because they feel like it and the television tells them to. What about you, Dr. Armstrong?
So if you look at the charted data, the low volume patients, such as this man, the hazard ratio for survival is 0.6. The p-value was non-significant with wide confidence intervals, but these patients do very well over many years, and it was really an underpowered part of that analysis. The STAMPEDE data, this man would have been eligible for the STAMPEDE trial, and that shows holistically that there was a survival benefit of docetaxel. So I would offer it to him. He may not accept it. He would do well with ADT alone. We have uncertainty about the low volume question, but at this time NCCN lists it, and I would offer it. Now there is updated data on the low volume question. Are you going to talk about that, Owen?
Well, I think yes. To an extent. We are aware that the low volume data is going to be updated at ESMO, and ultimately it certainly looks like the low volume patients are not receiving the benefit of docetaxel up front. This, to some extent though, I question low volume again is not low risk. 3 lesions and 3. If a patient has 4 small rib lesions versus 1 4-centimeter lesion taking up the right pelvis, who truly is higher risk? And I think there's a lot of room for clinical judgment in there. So I wonder, how do you define, I'll ask Dr. Hagano, I mean, who is the low volume patient, or what is the clinical definition of that in practice?
Well, just like you, I do not use that definition. So to specifically address this low volume hormone sensitive patient with metastatic disease, the reason I did not lean towards addition of docetaxel to ADT is because this is one of those patients that I just spent 20 minutes talking about, which is the guy that had primary therapy and then he had salvage radiation, and they do tend to have a more indolent progression. Now, that's not to say I wouldn't have a discussion with the patient about the data that there is and some of the unknowns, but I feel even more strongly about it now that, we haven't heard it presented. I mean, we've had discussions with Dr. Sweeney about the fact that the low volume subset of patients in the charted trial has a hazard ratio of 1.0, meaning that it's the same as not getting it. So, I wouldn't feel the need to be compelled to give this patient docetaxel at this point in time.
Let me ask a quick question of the audience just to be challenging. How many would radiate this patient's solitary or several metastases? How many would treat this as a focal therapy?
As oligometastatic disease.
Metastatic disease.
Both of the radiation oncologists in the room.
Yeah.
No, it's fair enough. No, and it's a legitimate question that we talked about including. Do you want to
some
comment?
over there, perhaps?
Mm-hmm. There's a handful.
Yeah.
Alan, can you show the forest plot for Stampede, for Charted, if you can go back? I just want to be controversial. So look at the previous local therapy subgroup. Those hazard ratios for men who had previous local therapy, yes, is 0.55. So that Ian Tannick hypothesis, I'm not sure is...
Yeah, but look at the numbers and look at the confidence interval crosses 1.
It is, but
so, yeah.
It's uncertain.
I don't buy it.
It's uncertain. But the point estimate is good.
I know, but this is one study where it's uncertain because it's underpowered for that subset. And I just presented 3 abstracts that tell me otherwise, as does my clinical experience. That's all. I know, you're just being controversial. That's why you're here, Andy.
We did plan this. We knew where we were going. So, yes, sir.
So I just wanted to, I'm a medical oncologist, not a radiation oncologist
Sure.
in Australia.
Yeah.
A lot of my radiation oncologists would offer stereotactic radiotherapy to these 3 lesions. Yeah. And they do it for the reason that it's simple, easy, non-toxic. And these are low volume, slow pacing, and live for years. Let's avoid the hormonal therapy for a couple of years. There's no data yet. It's happening all the time, though, at least in Australia. I'm interested in the panel. Is this a reasonable thing? Should we be doing trials in this setting?
So let me make sure I understand, though. You're saying that they're giving focal radiation therapy with no ADT.
No
right?
ADT. Their
Okay.
whole point is saying we'd like to avoid the exposure of ADT
I
for as long as
completely
possible.
understand. Yep.
Yeah, no, I think the rationale is certainly, easily understood and compelling. We certainly have these conversations every time we have to start ADT with patients. Low volume disease, why can't I do local therapy on the spot? And I think, you answered the question, which is we don't have the data. We have anecdotes. Most of us have seen the patient who had a lesion radiated, the PSA resolved, it stayed down for some number of years. I would argue, I do think that there are groups that do a lot of this, and yet none of them has come forward to say the actual PSA response rate and durable response is what. I think if the data was good, they would have reported it. Right?
I'm not sure I agree with that. I just think we don't have trials. It's easier to just give your SBRT and move on with the next patient. And, everybody can't be conducting trials. I think it's a really interesting question, though, because on the one hand, we have this thing, let's give everybody ADT and docetaxel, and this is like the 180 from that, right? Let's not give ADT, and let's zap the few lesions that we can see on bone scan. So, I think it's a great provocative thought.
I think the field is moving there. I think this study will happen. There's interest. There really is. We want to see it. We would have to argue over what's a meaningful duration of progression-free survival. I don't know the answer to that, but I think it's coming with any luck. Yeah. All right, so I'll move down a bit. All right, so following up then, of course, we had a range of answers here. Well, what is the data for low versus high volume disease? And so this is the published data. This is from GetTug, so a subset analysis that they did after the release of the charted data. And then this is the charted data as initially reported. Again, we're going to see an update of this data coming but we don't have those numbers out publicly yet. But at least as it stands, in GetTug, when they did the retrospective analysis, they could not reproduce the Sweeney data, the charted data, showing benefit in the high volume patients. And in charted, here again, the hazard ratios, they were the same, but the numbers were much lower in the low volume patients, and there were very few events, at least at the time of the initial report. But what about this population then? We have older data. This is SWOG 9346 that tells us that PSA response after initial induction, in this case it's defined as 7 months, is strongly predictive for survival. That patients who achieve a PSA of 4 or less after 7 months of ADT have a significantly improved survival versus, so this curve here, these are patients whose PSA after 7 months of upfront ADT is greater than 4. Here's 0.2 to 4 and then less than 0.2. So perhaps the biological test of just upfront ADT should be how we decide who should move on to chemotherapy. None of the 3 studies we've talked about actually address that question, but there is a way to pick out the more aggressive disease based upon familiar parameters. And in all of those studies, chemotherapy was started within 3 months of ADT. So there is some lag time to question whether chemotherapy is needed for the individual patient or not. And then simply the clinical considerations, because of course not every patient is eligible for docetaxel. We have to think about disease volume, but we also have to think about chemotherapy eligibility, performance status, comorbidities, life expectancy independent of prostate cancer, because of course there are those men who will have prolonged survival even with metastatic disease. And an emphasis on quality of life post-chemotherapy, those patients who will recover from the chemotherapy experience versus those who won't. And I think this is a distinction that we can make clinically. When you look at the patients on these 3 studies, age was quite young. Median age around 63, 64, and performance status was quite high. So in all 3 studies, over 95% of patients were either Konofsky 100 or ECOG or WHO 0 to 1. So this is not the average patient that presents with metastatic hormone-sensitive disease. This is a highly select patient population. And we can argue, without question, that there is no data to support upfront chemotherapy in patients with an ECOG performance status of 2. And again, as I was emphasizing before, this is really a question of early versus late chemotherapy because the ADT patients get chemotherapy later. So ultimately, we do at least have a meta-analysis of all 3 of these studies. This is a stopgap study. It was published in Lancet Oncology, combining the 4 different data sets, the 4 because we're talking about the stampede with or without the zoledronic acid. And certainly in a meta-analysis, chemotherapy added to ADT is the winner. But this meta-analysis doesn't get into high versus low volume disease because the stampede study hasn't broken patients down in that manner. So ultimately, docetaxel does prolong overall survival when added to ADT as first-line therapy. But the generalizability of the data to every patient is unclear. These are very select patients. And of course, impact on diverse phenotypes are unclear. What really is low-volume disease? There are multiple studies now looking in this space. Now that we've demonstrated adding drugs up front can be beneficial, multiple other studies will look at other drugs added either to docetaxel or to ADT in the upfront setting. This is just a partial list. So ultimately, the value of docetaxel is clearly established, but patient selection for appropriateness of chemotherapy is imperative. The benefit of docetaxel, I think at this point we should say definitively, is limited to high-volume patients, although we can argue over what that really means. But now what we don't know and what we have to start to figure out is how does upfront docetaxel affect subsequent therapies and all the assumptions that we're going to make treating in CRPC in terms of treatment selection. Thanks very much. And I'm going to introduce Dr. Armstrong. Dr. Armstrong is an associate professor at Duke Cancer Institute. and a diehard basketball fan.
Absolutely.
He tells me he is the Christian Leitner of the cancer world.
No.
Some of us don't even know what that
Everybody
means.
hates Christian lighters. That's not what I said. So Dr. Dorff and I are going to cover castrate-resistant prostate cancer in our 2 short talks.
And if you say castrate one more time, you're going to get spanked.
Castration. There we go. So let's start with a talk. This is a 70-year-old Caucasian male with prostate cancer. He had locally advanced prostate cancer, initially with a PSA of 15, intermediate to high risk. His metastatic disease workup initially was negative, and he chose a combined approach of external beam and palladium-103 brachytherapy as his initial therapy. He was treated with ADT as monotherapy during the radiation, adjuvant to that, and his PSA went down. But 6 years later, he had a PSA relapse in the setting of normal levels of testosterone. Restaging scans are now normal. He has no evidence of disease. He feels great, but is treated now with bicalutamide and ADT, combined androgen blockade. He's responding. PSA goes down. And approximately a year later, his PSA starts to rise, now with a rapid PSA doubling time. He's taken off the anti-androgen. Unfortunately, he has no withdrawal response. His testosterone is low, as you'd expect, on ADT, and his PSA is now shooting up to 11.2. He has this bone scan in the setting of low testosterone. He feels none of these symptoms that you might expect from seeing this bone scan. He has a CT scan that shows no visceral or nodal disease, and so thus he's asymptomatic. So we're going to talk a little bit about this box in the NCCN guidelines for castration recurrent or castration resistant prostate cancer. The term has evolved from endocrine resistant or hormone refractory prostate cancer, mainly because we now have therapies that are hormonal in nature that are shown to improve survival in this disease state. And so it's a more biologically correct term to use the term castration, even though patients obviously don't like to hear that. So we do talk about different degrees of hormonal therapy as we communicate the treatment options to patients. Frontline androgen deprivation therapy, anti-androgen therapy, androgen synthesis inhibitors. But the NCCN does emphasize the important point that we need to maintain low levels of testosterone as we add on these therapies. Now, if you're on a clinical trial, for example, at Johns Hopkins, they're experimenting with bipolar androgen therapy, and I think Dr. Dorff will briefly touch on that, where we're no longer maintaining that. But outside of a clinical trial, we're not doing that yet. Now, the important point of continuing anti-resorptive therapy is made here. As we've already mentioned, in the castrate or hormone-sensitive setting, there's absolutely no data to support denosumab or zoledronic acid, but when you get into the metastatic castration-sensitive setting, that's where the evidence lays. Immunotherapy with Sipuleucel-T. In the NCCN guidelines, we particularly mentioned that patients with short life expectancies, liver metastases, where they may not live long enough to see the benefit of an immunotherapy that may take 8 to 10 months to result in a separation of a Kaplan-Meier curve, may not be reasonable. And then palliative radiotherapy for painful bony metastases. If you follow the NCCN guidelines, as Dr. Agano mentioned, we have a branch point at visceral metastases, and we tend to not regard, as she mentioned, all visceral metastases as being created equally. In the upper branch there is for patients without bony metastases. That's where this patient falls in. So let's first start talking about immunotherapy. So Sipuleucel-T is really the only immunotherapy that we have right now that's approved for metastatic prostate cancer. Its mechanism of action is an immune target called prostatic acid phosphatase, really one of the first discoveries as a biomarker in prostate cancer. You can find it in Huggins and Hodges' Nobel Prize winning lecture where the tale of the two phosphatases was disclosed as being a biomarker of responsiveness to orchiectomy. And so PAP is a fairly ubiquitous antigen in prostate cancer. Antigens take up that PAP when it's fused to GM-CSF, which GM-CSF acts as an immune adjuvant that primes the dendritic or antigen presenting cell. It's expressed on the cell surface, that becomes activated outside of the body. It's reinfused into the patient, where you see at the immune synapse the engagement of T cells. And the purpose of Sipuleucel-T is really an infusion of dendritic cells that then activates the T cells within the body to then go to the tumor. This is a cartoon. This has not been demonstrated either surgically or with biopsies, although certainly at UCSF they've done a neoadjuvant trial which has actually shown immune infiltrates following this treatment into the periphery of the tumor. At Duke, we're doing a trial where we give Sapulocel T and then do a research operation and remove the lymph nodes, and we're actually learning about that immune synapse in patients who have received this therapy. All we know is that when you give this therapy with that dendritic cell followed by T cell responses, that there is a median survival benefit of about 4 months. There's a relative survival improvement of about 22%. The patients who tend to benefit are those that have a low burden of disease. As you make sense for immune therapy, the patients who have a more prolonged survival are those who have less energy, less tolerance perhaps to the tumor, less burden of disease for immunotherapy to overcome, and a longer life expectancy where the slowing of progression over time may be able to be more effective. As you can see here in these quartile plots, the patients with a low PSA, low is relative, under 22 in this case, had a median survival benefit of about 13 months, but more importantly, a relative hazard ratio of 0.51, which continues to increase as Sapulocel T is given at higher PSA quartiles at baseline, such that if you had a patient with a PSA over 130, there's only about a 2.8 median survival benefit. So when we've described our own institutional experience based on this data, our median PSA at the timing of Sapulocel T is about 7.5. And so we've adapted that therapy, and the NCCN has adapted this data to suggest that the earlier use of Sapulocel T, when the patient doesn't have an emergency need for cytoreductive therapy, may be the optimal time to intervene. There's important parts to know about Sapulocel T. It is approved. The toxicities, while mild, they can include fever, chills, and rigors. We have about 1 out of 100 patients that require Demerol for an infusion reaction. About a quarter to a third of patients require a central venous catheter, much like a dialysis catheter, which is certainly inconvenient for asymptomatic men who are often working. And we do see some men who have spinal disease, just like you'd expect with high volume bony disease, where a therapy that really doesn't have an immediate short-term benefit may not result in any reduction in the disease burden. The spinal disease may result in progression over time, and you may see spinal cord compression. And so certainly one of the considerations that I use in a patient where I'm considering Sapulocel T is, what is the probability that that patient may have a catastrophic event in the spine when I'm seeing them? So certainly a patient with very high volume bony metastases in the spine, we do an MRI. If there's epidural disease, we would radiate that before we would do an immunotherapy, where there's literally no resist responses, there's no soft tissue responses, there's no impact on PSA in the short term, and no impact on progression-free survival. So you have to realize that the NCCN guidelines recommends this really almost as an adjuvant therapy to our other therapies based on the survival benefit. But really for particular patients who would live long enough and are asymptomatic to minimally symptomatic at the time to receive the benefits from this therapy. So in this patient, he did receive this therapy. He was started on denosumab. You saw his bone scan, showed widespread bony disease. And post-Sapulocel T, as you'd expect, he developed new bone lesions. He progressed, and as you'd expect, he did not respond. We don't see responses to this therapy. His disease continued to progress, and he developed lung nodules, which, as Dr. Agano showed you, is not necessarily a worse prognosis compared with bone metastases. Very modest decrease in survival, but now his PSA is 114, his testosterone is low, his LDH is going up, his alk-phos is high, and he's still asymptomatic. So what would you do? This may generate the most diversity of answers, I would say. There's many choices. Would you observe this patient and rescan him in 3 months? He feels great. Would you give him abiraterone acetate with prednisone? Would you feel this patient's never had docetaxel? It's time to consider that. Enzalutamide. Is it time for radium? Would you throw your hands up? Got to advise the patient on something though. So that's a very interesting answer. We have some enzalutamide enthusiasts in the audience. Abiraterone and docetaxel are tied And observation and radium are tied. Great. So how do our expert panelists feel about this question? We generally agree with you. Dr. Bryce likes to answer twice.
Yes. I felt the need to do this on purpose, simply because Dr. Hussein and Petrolak aren't here to kind of advocate for their answers.
Does this mean you wish to combine those two drugs?
I think the appropriate answer in my clinic is to go on the Alliance 31201 study of enzalutamide plus or minus abiraterone.
Very good.
Yes.
And which arm are you hoping for?
Combination.
We'll see.
We'll see. Yeah.
All right.
So what I do think, though, we should comment on the abiraterone situation, because at least in some parts of the country, insurers will only pay for abiraterone first before enzalutamide. And I'm just curious, for a quick hand show, does anybody have that in their own practices? Are you the only one? You and me? We're it? Okay, well, anyway, it's just, sometimes it happens, and we do push back against that, and we can usually get them to cave, but not always.
No, that's correct. Many of the formulary decisions of insurance companies are now listing abiraterone first because of pricing differences, and that's just a reality of the cost of care. But if there's a contraindication to abiraterone, then you can often go to the next level of the formulary. So it all depends on what your beliefs are and what. So we're going to cover the data, and let's see if we can.
Yeah, there's one other quick thing I want to say about my own personal choice of enzalutamide. I mean, this guy just had CYP-T a few months ago. There's no data saying that this is really important, but at least enzalutamide does not require prednisone, whereas abiraterone does, and so that's just another reason why I would lean towards that, although either one is an acceptable answer, right?
I mean, insurers enforcing a selection of Abby first is not the least bit evidence-based.
No,
Right,
that's why we can push back against them, and they usually cave, not 100%. Depends on the medical director.
So let's talk a little bit about the situation where you have a patient with visceral disease. This is a relatively common situation. About a quarter of patients will have visceral disease at some point, whether it emerges from the beginning or at the end. When we talk about enzalutamide, this is considered a second-generation AR inhibitor. It blocks the dimerization, the nuclear translocation somewhat, as you can see in this picture. But more, it affects the chromatin binding of the androgen receptor and reduces the AR output transcriptionally. In the PREVAIL study, which is the most relevant trial to this patient, which is a chemo-naive, castrate-resistant randomized trial, placebo versus enzalutamide, we see the survival curves here, as presented both at ASCO, but then in the New England Journal this past year, which showed about a 30% relative improvement in overall survival and an 80% relative improvement in progression-free survival. Obviously, placebo does quite poorly in this situation where patients progress generally at the first or second scans on the study. If you see down here, there's a summary of all the secondary outcomes where the time to PSA progression, the overall survival now updated shows a continued improvement in overall survival. You see PSA declines that are pretty great for this disease condition. For example, bicalutamide in this disease situation, it has a PSA decline, PSA response rate of about a third, with enzalutamide resulting in about a 78% PSA decline rate if you use the 50% threshold. If you use 90% threshold, it's about 47%. Importantly, you can see soft tissue responses. These are real bona fide RECIST responses, 59% with enzalutamide. And the delay in the chemotherapy, which patients can hang their hat on. It's one of the goals of this therapy is to put off cytotoxic therapies that may result in a detriment to their quality of life is substantial. You also see quality of life responses. So even though you see patients who are minimally symptomatic, they still may have fatigue or some minor symptoms, and you can see that improve with an active drug, and you can see a decline, a slower decline in that quality of life over time. So this was just published in the past month or two. So we looked at the pattern of spread and how does enzalutamide do. So if you remember in the PREVAIL study, we did permit patients to have visceral disease at presentation in the castrate-resistant setting. And in the orange, these are patients with visceral disease, and in the blue are patients without visceral disease. And you can see the dotted line is placebo, the solid line is the enzalutamide. There's a wide separation regardless of the pattern of spread of your cancer. Same with overall survival, and while visceral patients, they tend to have a shorter overall survival as expected from Susan Hallaby's data, there is still a wide separation in between these. Now, it's a smaller subgroup, so the confidence intervals get wide with these subgroups, but the overall point estimates suggest that many of these visceral patients remain quite AR sensitive. The risks of enzalutamide are notable for fatigue, hot flashes, hypertension. That's one that many physicians forget, but abiraterone isn't the only drug that can induce hypertension. And grade 3 hypertension, by the way, is 160 over 100, and that's about 7% incidence with enzalutamide, and this generally doesn't occur with placebo. And these are often patients who don't have hypertension at baseline. The mechanism is still uncertain for this adverse event. Importantly, the fall risk is increased in these patients. We actually have exercise studies prospectively to try to reduce that risk. AR is a very potent signaling molecule in the skeletal muscle. And we can see, particularly in elderly men, Julie Graff published a paper just a few months ago showing that elderly men over the age of 75 do have a higher risk of falls. It's about 10 to 15%. Fortunately, the seizure risk was very low and equal in both the placebo and the enzalutamide groups at 0.1%. So seizure is not a big deal as long as you carefully select for patients who don't have a history of epilepsy or seizures or are not at high risk for seizures. There's an ongoing study of enzalutamide in men who are predisposed to seizure conditions that will help clarify that higher risk. But at this time, seizures are not a high risk in appropriately selected men. One important kind of post-marketing side effect that has emerged and is in the black box label of enzalutamide is this syndrome called posterior reversible leukoencephalopathy syndrome, or PRES. And this is a syndrome that's often described with acute changes in blood pressure. As blood pressure goes up, the occipital lobe tends to become edematous with vasomotor edema, and that can induce blindness, can induce a seizure, headache, lethargy, any drug that induces high blood pressure. Abiraterone is no exception to that as well, but can induce PRES. And so the management of PRES is to bring down the blood pressure. This is a reversible condition, but you have to be very careful with blood pressure control. And obviously, enzalutamide would be something you'd want to think twice about if that occurs. Abiraterone is an agent that works differently than enzalutamide. So if you think of enzalutamide as blocking the final common pathway to the androgen receptor, abiraterone blocks the ligand that leads to that androgen receptor engagement. So abiraterone blocks the hydroxylase version of androgen synthesis enzyme as well as the lyase. You've heard at this meeting about some of the newer agents that may just work on the lyase, but when you use abiraterone, cortisol goes down, dihydrotestosterone goes down, and the body reacts to that by upregulating ACTH. That upregulates mineralocorticoids. So the most common side effect of this drug is called mineralocorticoid excess, or CON syndrome. That's characterized by low potassium, high blood pressure, salt wasting sometimes, lower extremity edema. And the consequences of low potassium could be atrial fibrillation. The consequences of fluid retention could be cardiac failure. And so this is particularly important to manage with home blood pressure monitoring, to monitor electrolytes, as well as liver dysfunction, which has nothing to do with this, but electrolyte monitoring, hepatic monitoring is important. This is one of the reasons that we give this drug with prednisone. When you give the drug with prednisone, now you've blocked that feedback upregulation at the pituitary level that downregulates the mineralocorticoids. So this endocrine loop is in part blocked, and the safety and the efficacy of this drug are improved. Many of these mineralocorticoids, progesterone, corticosterone, aldosterone, are weak androgens, and they can act at the receptor. So by using prednisone, you reduce the androgen levels, and the efficacy is actually improved. And many have shown that further addition of dexamethasone, for example, may improve that efficacy, and the safety is as well improved. So the summary data with abiraterone, this is the relevant 302 trial, which was chemo-naive patients, demonstrated superiority not over placebo, but over prednisone alone in terms of overall survival, as well as progression-free survival. Notably, the placebo patients who had prednisone do a lot better than in the PREVAIL trial, where it was a true placebo, where it was about 4 months. Now we're at about 8 months with a prednisone control. Overall survival, however, prednisone's never been able to demonstrate a survival benefit, is still about 30 months with really a placebo. The secondary endpoints of this trial, just like in the PREVAIL trial, demonstrated a delay to chemotherapy, an improvement in PSA progression-free survival, a delay in progression-free survival, pain responses in the post-chemotherapy setting, and a delay in the quality of life detriment. So again, this, as Tia mentioned, this has not been evaluated in men in the chemo-naive setting with visceral metastases, but it has been evaluated post-chemotherapy in men with visceral metastases, demonstrating good outcomes. If you look at the side effects, as I mentioned, mineralocorticoid excess is highlighted here. These are important to consider and monitor in your patients, as well as liver injury. Atrial fibrillation is slightly increased because of these fluid shifts and electrolyte changes. Cardiac disorders also slightly increased. If you compare the drug characteristics, this is not meant to be an efficacy slide. This is more of just how do you dose the drugs, how do you monitor patients. They're both oral. One requires prednisone, the other does not. They both have drug interactions. Enzalutamide induces CYP3A4, while abiraterone is more of a substrate. Enzalutamide does lower the seizure threshold, while abiraterone has not been shown to do that. Abiraterone does have liver toxicity, enzalutamide does not. They both cause hypertension. They can both increase the risk of things like atrial fibrillation, abiraterone perhaps a little bit more. And the dose is 4 tablets or capsules a day. Enzalutamide is taken with or without food, and abiraterone is best taken on an empty stomach. We've actually recently published a paper of what happens when you give abiraterone with a full stomach when you have resistance on an empty stomach, and we have about 20% of patients who respond to that approach. So the timing and selection of secondary AR-directed therapies, in my mind, the choice of abiraterone and enzalutamide is not based on efficacy. Similar overall survival, similar PFS from cross-trial comparisons. Enzalutamide has been evaluated in men with visceral disease, of course, but both are listed as Category 1, and the NCCN appropriately has them both as Category 1. And the choice is therefore based more on differential toxicity and individualization of care. So if you have a patient who's seizure prone, they've had a recent stroke or a hemorrhage, perhaps enzalutamide is not the appropriate case for that man. Abiraterone may be more appropriate for a more frail elderly patient who's had significant falls, but enzalutamide may be more appropriate for a patient with brittle diabetes where you're concerned about immunotherapy and you don't want to give prednisone, patients with metabolic syndrome. So there's many considerations at the individual level that you might choose one of these. And generally the first drug that you pick will be the most important, and as Dr. Dorff will get into, there's significant cross-resistance between these drugs. So your first shot on goal is going to be the most important one. Your second one, not as important. So the practical aspects, how do I prescribe enzalutamide? It's obviously 4 40 milligram capsules taken once daily. There is some newer capsule formulation coming out. I think that's going to be 2. I do recommend home blood pressure monitoring. I do this for abiraterone and enzalutamide because of the 7% risk of severe hypertension. I encourage all men to exercise who are on ADT, but I particularly make note of that when they're on more potent AR blockade. I don't give any driving or flying restrictions. I have a number of pilots who are fine taking enzalutamide, but if you have epilepsy or high risk of seizures, I'd probably avoid this agent. Or we put them on the enzalutamide seizure study. And you do have to be particularly careful about concurrent medications that lower the seizure threshold. Now for abiraterone, the prescription is 4 500 milligram tablets taken an hour before you eat or 2 hours after food. Taking it with food increases the bioavailability about 300 to 400%. And again, home blood pressure monitoring, the blood pressure risk is about 5 to 10% here. There is a specific antidote to mineralocorticoid excess, so if you think that the blood pressure is caused by that mineralocorticoid excess, there's a drug called eplerenone that blocks that pathway. Exercise is also encouraged to reduce the fall risk and fatigue. I do monitor electrolyte and liver function and renal monitoring, particularly every 2 weeks in the first 3 months and then every 12 weeks. And in particular patients, because of the risk of cardiac disorders, Particularly if you have a patient who's predisposed, who has pre-existing coronary disease, I'd consider an oncocardiology evaluation. All right, one thing I do want to emphasize with these two drugs is that there's bone scans can often mislead us. So when you use these drugs, here's an example of this. This patient started with a PSA of about 200. He has a sternal metastasis. His PSA goes down to about 12 weeks later. He feels asymptomatic, and he has this new lesion. And before prostate cancer working group 2 came out, this patient would have come off of whatever drug he was on for radiographic progression. So how many people think that this is radiographic progression? Great. Okay, so this is called bone scan flare or a healing reaction. You've all seen patients who've gotten a fracture. The bone scan can often light up. That's not because there's a metastasis there, it's because of osteoblastic activity. This patient probably had a lytic lesion or a small volume met that just wasn't seen in that rib, and this is healing. And the working group 2 guidelines really state that we should keep that patient on these drugs if the patient is doing well and they're otherwise clinically responding. And indeed, about 2 years later, he continues to do well with that unconfirmed new progression, and his PSA continues to fall. And so this flare phenomenon, where at the first assessment you can see new lesions, is not a reason to stop a drug, and this is actually very common with both ENZA and ABI. It's about 40% of patients. So we use that 12-week scan really as a new baseline to then go forward to say, is that patient going to have ongoing new lesions? That may be a reason to stop. But of course, you have to look at the patient, determine if the patient's having increased pain, if the PSA is going up, then that's not going to be flare. Patient 1 continued. He starts ENZA, he maintains ADT, he's put on denosumab, his PSA does great, but unfortunately his PSA starts to drift upwards again about 12 months later. His bone scan is stable, but now he's got migratory bone pain, no visceral or bulky nodal disease. Let's discuss this case now. So migratory bone pains, no visceral disease, which of the following would you recommend for this patient? Would you now add radium? So he's on ENZA, he's on denosumab, he's on ADT. Would you add radium? Would you take him off ENZA, switch to ABI? Would you take him off ENZA, switch to ABI and add radium? Would you switch to Kabazi? Would you switch to docetaxel? Let's not answer unsure. All right, so we like the adding radium idea. We also have some docetaxel fans. We have some switching and adding abiraterone with radium. Not many people believing that abiraterone is going to benefit the patient at this point. And on Monday, I think we'll see some Kabazi Taxol data that hopefully that 4% will go down. All right, our expert panel, we're all over the place. So some like adding radium.
Can I just say something?
You may, of course.
You know what? This just shows how challenging this is. So, you know, there's most of the time these no clear wrong answers, but, you know, you just have to be able to understand why you answered or recommended whatever you did. That's all.
You have to be able to defend yourself, that's
Yep.
for sure.
Yep.
So I'm the only one who said to switch to ABI and add radium. That's generally my belief that ENZA continuing in this disease is not going to help the patient. So I'm looking to switch to a different AR-directed therapy, but I'm not confident that ABI is the answer. So I'm giving him 2 drugs, not 1. So that's why I picked that. How about Tia? Why do you like docetaxel?
I'll tell you why, but I'll tell you why I didn't answer either just add radium alone or switch to ABI and radium. Because you already have kind of got me thinking about, well, this guy was on ENZA for a year.
Yeah.
And so probably switching to ABI, you know, might not do anything. Might already be cross-resistant. And then radium, you know, you could, by the trials, you could add that. But this guy, I'm smelling the fact that he's starting to progress. And radium has to be given over 6 infusions over 5 months, right? So that combination of ABI might not work, and he might not be able to get through radium to the next therapy. That makes me just say, let's just go with docetaxel now, cytoreduce because I know what I'll get with docetaxel. And then maybe after 6 cycles or 8 cycles of docetaxel, I can then go to radium.
Sure. Alan, you agree?
I think Dr. Dorff's presentation is actually going to answer this, and then no one will do abiraterone plus radium.
Now wait a second. I do need to speak to that though, because there is an ongoing phase 3 trial looking at abiraterone with or without radium. But again, this is in a much earlier patient, right?
Right, not
That-
post-ENZA.
Not post-ENZA. This is supposed to be in asymptomatic patients who are early in the course of metastatic CRPC, and where, we could use ABI, but ordinarily radium hasn't been added. So this trial will be very important for a combination in terms of where, if anywhere, does this combination belong in treating our patients.
So it sounds like you feel in the future radium would optimally be given in an asymptomatic patient.
I don't know. I think that whatever it is, we don't want to give radium when we can only have a chance to give a dose or two, and then we have to move on to something else.
Right.
I think that's been a big learning curve for a lot of us. We want to give it when we can try to get at least 5 or 6 doses in. And I don't know, is there any kind of controversy about that over at that table over there? Okay.
I think Dr. Dorff was going to cover radium pretty well, but it is a calcium mimetic. That's why it acts as a Trojan horse. It's taken up by the bone, thinking that it is calcium. It's taken up by osteoblasts, which then emit, the radiopharmaceutical emits little helium particles, which are alpha particles at the tumor in those osteoblastic regions. And so the mechanism of action is really a bone-targeting radiopharmaceutical of alpha particles, and it's the only one approved. It's based on the Alsimca trial, which was largely a European study. It did involve a handful of U.S. patients, but it was done before ABI and ENZA really were developed. In this trial, they randomized patients to radium over 6 months, monthly, plus best standard of care versus placebo plus best standard of care. And in Europe at this time, the best standard of care largely involved drugs like bicalutamide, estrogens, corticosteroids, and external beam radiation, which could be given concurrently. And the patients in this study were symptomatic CRPC. They had 2 or more bone lesions. They did not have visceral disease or bulky adenopathy. And they were either post-docetaxel or considered by their doctor to be unfit for docetaxel. This is the survival data, which I'm sure you're all aware of, showing a 30% relative improvement in survival. I just want to point out some of the subgroup analyses, which I think are particularly interesting. Some of the patients who have a relative better hazard ratio for the survival benefit of radium are those with a high volume of bone metastases, a high alkaline phosphatase level indicating more osteoblastic disease and perhaps more uptake of the radium in the bone. Benefits regardless of previous docetaxel use. Benefits regardless of concurrent or prior bisphosphonate use. This drug came out before, it was developed before denosumab, so we don't know much about that. And beneficial regardless of whether the patient was on opiates or not. The downside is really quite modest. We actually see fewer severe adverse events versus placebo, but there are some notable exceptions to that, mostly mild thrombocytopenia. Mild neutropenia, this is excreted into the GI tract, so you do see some constipation or diarrhea, but it tends to be grade 1 to 2 in nature. In patients with super-scans, you can see pancytopenia. There have been reports of aplastic anemia and severe marrow suppression that may not resolve. So you do have to be cognizant of patients with very high bone marrow involvement. So that's almost all I have to say. This is the data recently updated in Lancet Oncology showing a survival benefit regardless of prior docetaxel use. And so the general guidelines is we give this either with a radiation oncologist or a nuclear medicine radiologist who's clinically trained in radiation safety. It takes about 60 seconds to give, so it's quite easy. It's once every 4 weeks for 6 infusions. There's really no pre-medications. We do check a CBC a week before, so when it's shipped from Colorado to your site, they'll know that it's safe to give and that you're not wasting a very expensive medicine. The primary benefit is really survival again, so you're using this for the survival benefit. You don't see PSA declines. You don't see soft tissue responses. This is not a drug that gets into the soft tissue, but you do see a delay in clinically important skeletal events, particularly spinal cord compression. But again, just like Sapulus LT, spinal imaging is important because one of the ways that the disease resists radium is to grow where radium will not go. Okay, so it will grow into the epidural space. It will grow into the brain. It will grow into visceral or soft tissue disease. And that's what we see when we look at patients who progress on radium. NCCN guidance is level 1, category level 1 evidence, bone predominant disease, symptomatic disease with or without before or after docetaxel. Patients should be followed carefully for bone marrow toxicity. You're supposed to continue ADT, continue steroids, continue anti-resorptive therapies, consideration of palliative radiation therapy if you have a particularly painful focal area, which you can give concurrently with radium. And so that's really all I have to say. Dr. Dorff is going to talk a little bit about the next steps, so the future. I did have a clinical trial slide, it got deleted, but we're very excited about obviously combining some of these agents. We're looking at biomarkers that may predict the benefits of one drug versus the other. We're looking at these agents moving earlier, both in the hormone-sensitive setting, but combined in the hormone-resistant setting. But in eligible patients, we have a long list of menu options now for patients that include immunotherapy, radiopharmaceuticals, AR-directed therapies, and taxanes. Great.
So thank you all for staying. I think this part of the talk may be the most exciting part because we're not just looking back at what we know, but we're looking forward at what's coming down the pipeline. So hopefully it'll be worth your while to have stayed. So the first case I present is maybe bringing it back to what Dr. Higano initially presented. This is a guy who walks in your door who you know has bad disease. He's young, he's metastatic at presentation, and he presents with spinal cord compression. So this is a guy who is not going to do well, even though he's the nicest guy in the world. So he does well initially, but develops early castration resistance. That is another really bad hallmark, as I think was alluded to earlier. Nevertheless, he's still asymptomatic, and nothing's really changing as PSA is slowly rising. So we managed to get CYP-T into him, and then we put him on abiraterone when PSA continues to rise. So then he responds but progresses, which is what we expect. His PSA hits 2, but nothing's changing on the scan, and he feels good. And I'd just like to point out, he gets another year on this agent before he starts to actually develop pain. So just like in the clinical trials, we really keep going until there is clear progression. We don't tend to bail just for a rise in PSA. So let's talk about what choices we have for this gentleman who's now progressing clinically on abiraterone. I know we talked about this a little bit already in the last case, so we don't have to belabor the discussion. Okay, so most people are preferring docetaxel, but also some for radium, and I think really either one is perfectly acceptable in this setting. It's also, of course, reasonable to switch to enzalutamide, but that's kind of what we're going to talk about next, is whether we think that's the most effective choice. So when we looked at our experts, you can see that there's also some variation. There's not one right answer here, and you, just like someone alluded to, you make a choice that makes sense to you and to the patient, and a lot of it happens in the room as you're discussing it together. So we've seen the survival advantage of all of these agents, but what I want to point out here is that many of them don't speak to how well these agents perform in this gentleman. Someone who's had abiraterone was not on any of these clinical trials. So we're operating a little bit more in the dark. Fortunately, some retrospective case series have stepped in to fill the void a little bit. And what we see is waterfall plots that are not what we expect when we use abiraterone or enzalutamide as the first treatment for CRPC, right? We usually expect that waterfall plot to be going down, and here we have a fair number going up for abiraterone after enzalutamide, and also enzalutamide after abiraterone. So we know that there's some similarity in mechanism of resistance to these agents so that we don't get as much bang out of the second one. Docetaxel, which is the the gray bars on the graph on your right, is maybe more of a waterfall plot that you would expect, and we'll talk about why in a moment. But I want you not to be biased thinking that my slide presentation is designed to tell you that you don't switch directly from one to the other, because actually you do get some people who respond to both, right? It's not 100% similar cross-resistance. But I love this graph. I think it's so telling about how much we don't know about our prostate cancer patients. Who are these guys who respond to one drug but not the other? Who are these guys that don't respond to either? Are those the de novo ARV7, which we'll get to in a moment? But again, you don't see as many responses, but you do see responses. So it's not that it's not a reasonable choice. It's one of your options. So ARV7 was just talked about a lot in the prostate poster discussion session, if some of you were there. This is work that's been done at Johns Hopkins and was probably the most exciting story in the last couple of years. So by drawing CTCs, circulating tumor cells, and isolating androgen receptor and looking at splice variants, especially the ARV7, which loses the ligand binding domain, you can see that, again, we're getting waterfall plots that aren't as pretty as what we expect. So if you are a blue bar, you don't have ARV7, well, you respond to enzalutamide, you respond to abiraterone. But if you have the ARV7, if you have this abnormal androgen receptor, you're a yellow bar, you don't tend to respond nearly as well to these agents. So there is perhaps some explanation for why we see that lack of advantage when we switch agents directly and the similar mechanism of resistance. But the key piece of evidence was really presented by Dr. Antonarakis last year, which is to say that docetaxel is not affected by this ARV7 status. So this is exciting, potentially, if this is validated. So the New England Journal paper had a very small number of patients. What was presented today at the poster discussion session was a much larger cohort. And it did uphold this initial evidence. But potentially what we would like to have in the future is a test where you can draw the patient's blood and say, okay, now I have a reason to pick drug A versus drug B. Maybe you're better served by chemo. Maybe you're someone I can get away with continuing on an androgen receptor targeted agent. So we've gone through docetaxel and cabazitaxel and radium-223. What I want to highlight here is just the fact that, again, these guys didn't get enzalutamide and abiraterone. There's a bit of a knowledge gap as to how much bang you get for your buck. And also, I think there's more excitement about it. When I started practicing 10 plus years ago, there was a lot of nihilism. Chemo doesn't work in this disease. And then Charted came around and really changed how we feel about chemo. Chemo might actually bias a lot. So we were having abiraterone and enzalutamide. Chemo is getting pushed further and further. But now I think maybe our thinking is going to have to shift back again. We're using it early. Maybe we're interspersing it between ABI and ENZA to hopefully get rid of the ARV7 population. And there's a lot of great work being done that might uphold that theoretical appeal. Cabazitaxel, survival advantage in a docetaxel pretreated setting. But again, I looked in the Lancet paper. I didn't see any mention of ABI or ENZA, and I think this came up really before most patients would have had an opportunity to get exposed to those drugs. You just heard a lot about radium. So when I first treated a patient with abiraterone and decided to be bold and add radium-223 in the absence of data, the guy had florid hepatic toxicity, and I was spooked. I thought, wow, maybe there is overlapping toxicity even though we wouldn't necessarily expect it, and maybe I do need to wait for the data. But fortunately, we didn't have to wait long. Some data sets stepped in to fill the void. So in the expanded access program, this is about 180 patients. 22% got concurrent abiraterone or enzalutamide, and you see no difference in the treatment emergent adverse events. The Tulane and Cleveland Clinic cooperation is about 50 patients, but up to half of those got concurrent ABI and ENZA, and again, we're not seeing any signal that there's additive toxicity. So it seems at least there's preliminary evidence that you can use them together safely, and I've started doing it again after my initial bad experience. There's an interesting paper that just came out suggesting that perhaps the combination is better, but this is not level 1 evidence. This was not a prospective randomized trial. And very importantly, so in this paper they showed that when you added Abi with radium that they seemed to do better, but a third of the patients had nodal or visceral involvement. So I think maybe it's not a surprise because we know the radium's not going to handle that. It's targeting the bone. Abiraterone maybe made its contribution by controlling nodal and visceral disease. But some people are starting to talk about the fact that maybe the combination is more effective. But I would say we really need prospective data to make that claim. So there are some prospective trials. This one's done. The middle one, it was a company-sponsored trial, radium alone, or with abiraterone, or with enzalutamide. It's not large enough to really answer a survival benefit kind of a question. It's, I think, more aimed at just answering that safety question, maybe giving a signal. So it's finished accrual, but not yet reported. This is a larger study that was alluded to earlier of abiraterone alone or adding that radium early. And I think that's going to be really important in helping us understand, because we've been serial sequential treatment paradigm people in prostate cancer, just like in breast cancer. And maybe that's going to change. Maybe combinations are going to be better, but we need these randomized prospective data. So my little mini soapbox is that out in the real world where you're treating patients, if you go through all your ABCD, your Abi, your Cabazzi, your docetaxel, Enza, and then send them for a clinical trial, these questions don't get answered, right? So we have to think about clinical trials as one of the earliest things to look at for our patients because these trials provide very, very meaningful data that we can then use to counsel our other patients. PRIM-CAB is a super interesting study. That's the design that's here. So taking someone who's progressing on Abi or Enza, just like our patient in the vignette, and randomly assigning them to chemotherapy, here with cabazitaxel, or to switch to the other AR-targeted therapy. So if they were on Abi, they go to Enza. If they were on Enza, they go to Abi. Unfortunately, we just got word last week that there's been slow accrual and the trial is going to shut down. But isn't this a piece of data you'd really like to have? Maybe it will be reinvigorated in some ARV7 form, I don't know, but this type of trial would provide very useful information. So going back to my gentleman, we ended up giving him chemotherapy, later on enzalutamide, radium-223. I just wanted him to get everything so that we could get to sort of the interesting, let's look forward part of the talk. His PSA is rising again, but he's still young. He's not yet 60. He's still got good performance status and organ function. So what are we going to do for him now? Do you recycle abiraterone? Do you pull in cabazitaxel? It's the one thing I didn't throw at him yet. Is he ready for hospice or a clinical trial? Okay, so many of you would consider a clinical trial. Many would use cabazitaxel. I think that's perfectly reasonable, especially because, let's be honest, there aren't so many clinical trials out there for prostate cancer patients who have been through these lines of therapy. But we didn't ask the experts because we anticipated they would all vote for clinical trial. So we're going to talk about some of what we might hope to see in clinical trials for such a patient, some of the approaches that we're trying to use for prostate cancer, including immunotherapy, some additional androgen receptor targeting, believe it or not, even beyond Abi and Enza, and then some completely different targets that are non-androgen related. Immunotherapy exists for prostate cancer, as we heard. We have Sipuleucel T. But aside from that, it's had sort of a hit and miss experience in prostate cancer. So we have some very positive phase 2. So if you look at this, it's the poxviral PSA targeted, also known as PSA Tricom. The phase 2 looked positive. The phase 3 not yet reported. But before we get too excited, the phase 2 for GVAX looked very promising also. And then the phase 3 program with Vital 1 and 2 didn't pan out. So we really do need to wait for those phase 3 data. Similarly, ipilimumab, here's the phase 3, the blue and red curves on the bottom. Unfortunately, it was a negative trial in the post-docetaxel setting. As far as I'm aware, pre-docetaxel, that trial has not yet been reported. And yet we saw some responses with ipilimumab. So maybe we just need to learn which patients to target. There's a listeria-based vaccine that's in trials, and we have yet to define a role for PD-1 inhibitors in this disease. So ipilimumab definitely works for some prostate cancer patients. And again, I think the challenge is figuring out who, and then maybe we could have a more positive outcome in a trial. But it does come at the cost of toxicity. And our prostate cancer patients are really used to having treatments that don't necessarily cause a lot of toxicity. They're LHRH, they're sipuleucel T, they're radium, so I had patients say no to the clinical trial when they looked at the potential side effects. So we have to be cognizant of balancing risks against benefits, particularly I think in this patient population. They also are more elderly, more previously irradiated, and may just not have as much immune system bandwidth to be activated. So what are we doing to try to make immunotherapy work for us in prostate? We're jealous. All the other tumor types seem to be getting lots of immunotherapy advances. Well, one strategy that we're using in prostate cancer is adding radiation. So when radiation kills a cancer cell, it kills it in a way that's very immunogenic. So maybe in addition to pushing the immune system to be active, we need to pull it into the tumor. So there is a trial of sipuleucel T combined with radium, and then there will be, not yet opened, a radium plus atezolizumab, which is a PD-L1 inhibitor. So there's no clinicaltrials.gov number that I could provide for you yet, but it will be opening. Another way we could try to make immunotherapy work better, and this is something they're doing in other tumor types, is combine multiple strategies to activate the immune system. So building on sipuleucel T, we have a trial adding ipilimumab either early or later. We have one with a checkpoint inhibitor and cyclophosphamide, which is purportedly used to reduce the T regulatory population. There are lots of different antibodies. This is a very, very minimalized diagram of things we can activate or suppress to try to get better immune activation, and we'll probably start to see more and more variations on this theme. One trial that's open right now in a cytokine intergroup is this subcutaneous IL-7 on the bottom, where once you finish your regular old CYP-T, you either are observed or you get 4 doses of sub-Q IL-7, which is also an interesting strategy just to try to ramp up the immune response that we've seen in previous years does happen after you give sipuleucel T. Androgen receptor we target in 2 major ways, right? We can target the ligand by blocking testosterone production, or we can block at the level of the receptor. There's a new drug in clinical trials, galeterone, that does both. So it has both the ability to block CYP17 and the androgen receptor. And whereas the drugs that do these only one or the other, so abiraterone CYP17, enzalutamide androgen receptor, we saw that those don't seem to have as much activity in ARV7. In preclinical models, this agent does seem to work in ARV7, which kind of unexpected, I would say. But even beyond the preclinical, there's some early clinical data. So if you take a naive patient, you're going to get a beautiful waterfall plot, and that's what you see with galeterone as well. But this is the kind of more exciting experience, which was they found that some patients with ARV7 had these good, robust PSA responses to galeterone. And so this forms the basis for the ARMOR-3 trial, which is really exciting, but it's really early. So you have to screen patients right when they're failing their first hormone therapy. So when they're first castration resistant, before they've had Abi or Enza. So we know there's going to be a very low rate of ARV7 in those patients. We know we're going to have to screen a lot. But only if they have ARV7 do they get on the trial and they get randomized to galeterone or to enzalutamide. So this is a great trial because we may get not only a new drug, but also a new biomarker that's actionable, that might help guide us when we're in the room with the patient looking at the NCCN list and saying, what's best for me? So I would encourage you to support it if you have an ARMOR site near you. As was alluded to earlier, there is a concept of giving back testosterone. So you may remember some years ago, people gave testosterone and then docetaxel to see if you could drive proliferation and then wipe out the cells. It didn't pan out. Here, the thinking, if I'm correct, is that you give the testosterone to upregulate androgen receptor expression so that your androgen receptor blocking therapies would have a better chance of working. So this is in hormone sensitive, but presumably, if it pans out, could be moved into later stages of the disease. And this is, of course, I think a holy grail for our patients, right? Most of our patients are interested in not necessarily always having absence of testosterone. I don't know with these pulses how much they actually feel. I think it'll be interesting to see not only the outcomes on the disease, but is there a quality of life difference for them as well. And finally, non-androgen receptor targets, the most prominent of which is probably the class of drugs that are PARP inhibitors. So when your DNA is damaged, PARP is one of the many redundant pathways we have to repair it, so that when the cell cycles and divides, it doesn't die. PARP also has many other functions. And so the New England Journal paper studying olaparib in castrate-resistant prostate cancer made a big splash. People were excited. This drug can work, but it seems to be primarily working in patients who already have one hit in their DNA repair system. So all these non-responders largely had no underlying defect in DNA repair, and the response rate for olaparib was much higher in these patients who had BRCA, HCM, or one of these other defects in DNA repair already existing. So here's essentially a biomarker-driven treatment that is on the horizon. This was a small preliminary trial. It's not approved yet for MCRPC, but a lot of patients are asking about PARP inhibitors. So there's an abiraterone alona with ABT888 trial that's completed, and hopefully we'll see that read out in the next year or two. We also today at the poster discussion session heard a little more about this J591 radiolabeled antibody. It's an antibody against PSMA. So you may remember prostate scans were targeted against PSMA and they weren't very good, but that was targeting an internal binding domain of PSMA, whereas this antibody targets the external domain. So they've looked at this radiolabeled PSMA antibody as both for imaging purposes and treatment. So here you see in the imaging that it corroborates what's seen on the bone scan. It lights up in areas that a traditional bone scan says are prostate cancer, but it finds some areas that the bone scan doesn't. And at treatment doses, you can induce PSA responses. And again, the phase 2 was presented as a poster earlier today, showing, again, some interesting activity. There is definitely myelosuppression, so this isn't maybe as specific as we'd like it to be, and we knock out some of the marrow. So I encourage you to look for that information, maybe on virtual meeting. The PI3 kinase pathway is the final pathway, I promise, that I'm going to talk about. This is very important in prostate cancer because many prostate cancers have PTEN deletion, and this allows for enhanced signaling through PI3 kinase and AKT, and there's also crosstalk with androgen receptor. So a really rational target. It has an agent that inhibits PI3 kinase that's been tested. I know this doesn't project well, but believe me, the bottom section is CRPC, and at relatively low doses of this agent, the red and black kind of doses, you see these very prolonged responses. And then we have our obligate CAT scan showing you the objective response in a prostate cancer patient. So there is an ongoing trial with this agent for patients who are progressing on enzalutamide. You then continue the enzalutamide and add in this PI3 kinase inhibitor. But the patients are only eligible if they have PTEN deletion. So we're seeing a theme, maybe, that we're going to start moving towards an era where we try to select out enriched populations for our studies as we get more granularity about who these different kinds of prostate cancer patients are. So androgen receptor still remains a major driver, but I've shown you some other targets that we're hoping to have available for therapeutic use in the future. And sequencing, it remains an open question, but hopefully you've gotten some of the data to help guide you in your decision making back in clinic. So thank you.